Hello, welcome, bonjour, everybody. We're just opening up the chat room. We have over 450 people registered, so we're just going to give a moment and then we're going to get ready to start. So good morning, good afternoon, or welcome from wherever you are watching us today. My name is Dr. Samir Sinha, and I'm the Director of Health Policy Research at the National Institute on Aging. And it's a real pleasure to invite you to be part of our first in a series of webinars that we're presenting related to dementia in Canada. So welcome, and we look forward to having you with us today. Oops. Here we go. So I want to just welcome everyone, and please note that all audience members' microphones are muted as of now. But if you have any questions for our speakers, please use the Q&A box at the bottom of your screen. So that's where you can ask any questions that you'd like us to answer for you as well. But if you have any technical issues, please let us know in the chat box as well. So again, thank you very much for joining us today. Before I introduce our guest speaker today, I just want us to do a land acknowledgement. The National Institute on Aging is located in Toronto, which is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans and all newcomers, have been invited into this treaty in the spirit of friendship and respect. And so now I wanted to introduce my colleague, Dr. Serge Gauthier. Bonjour, hello, Serge. Serge is an academic co-lead of the Dementia Education Program, and he's a professor emeritus in the Department of Neurology and Neurosurgery and the Department of Psychiatry at McGill University. He's going to be presenting to us around reducing your risk of dementia, evidence-based advice for Canadians of all ages, and health professionals. Serge, over to you, and then afterwards, we're gonna do some Q&A. So we'll invite people that as Dr. Gauthier is sharing with us his knowledge, that if you do have any questions, please put them in the Q&A. And again, if you have any technical questions, you can put those in the chat. Serge, over to you.
Thank you, Samir. Good afternoon to all of you. Bon après-midi, tout le monde. It's a pleasure and an honor to share with you some information. I'll tell you where you can read more about that as we go along. So now I'm trying to move the slide forward. There's a lag time. I'll click again. Okay, so to put in context, what we're discussing today is dementia as a generic term that's been around for at least a century. It's an umbrella term. It's decline in cognitive abilities affecting daily life. And it's caused by different conditions such as Alzheimer's disease, which is the best known and most common over age 65. There's also vascular dementia, which is not as common. It's usually a mix of both Alzheimer and vascular components. Even more rare are Lewy body dementia, which is Parkinson-like to some degree. And many people have both Alzheimer and Lewy body dementia. And the least common illustrated here is frontotemporal dementia, which is unfortunately more common in midlife 50 to 70-year-old people. So dementia umbrella term, what we're discussing today is risk factors that would apply to some degree to most of these conditions. Okay. So some factors you cannot change. It's such as age. The longer you live, the more likely you are to get dementia. But not everyone gets dementia. Even over age 100, not everyone has dementia, although most people will have in their brain changes that we can see with the microscope and some biomarker studies. But not everyone has symptoms. So a lot of the research that's going on with centenarians is what's protecting many of them against the effect of brain aging and why they do not all have symptoms. And now in Canada, we are living longer than our parents and grandparents, and there are projections made. And I know some of you would like to know some hard numbers. So for instance, right now, as of January this year, we have over 71,000 people with dementia. And if we don't modify risk factors, in 2030, we'll have 1 million Canadians with dementia of whatever cause. And at 2050, we'll have 1.7 million people. But the good news is, despite aging of our population, because we're in good general health, there should be less people than expected if we use the modifiable risk factors well. And that's the purpose of our discussion today. Sex and gender. So women are more likely to get dementia than men, and it's not just because they live longer on average than men. There's some other factors at play that are being studied. It's one of the research priorities in Canada. In terms of what causes dementia, for Alzheimer's disease, clearly women more than men. Parkinson kind of dementias, it's perhaps even slightly more men than women. So it's not 50-50 right across. And there's research going on now why sex and gender plays a difference. Unfortunately, making more women at risk. Genetics, that's a popular topic also when you talk to a general audience. If my mother had Alzheimer's at age 90, do I have a higher risk? The short answer is no. But if you say your mother had Alzheimer's at age 70, yes, you possibly have a slightly higher risk because you may have inherited from her side of the family a weak gene, not a causative gene, that affects cholesterol transport. So this ApoE4, which is a Canadian discovery by Jude Poirier and his team, is now accepted as a risk factor, a biologic genetic risk factor, but it does not cause dementia or Alzheimer's disease specifically. If you happen to have two copies, so both sides of the family gave you this weaker gene, ApoE4/4, then you're at higher risk of having dementia, but it's not common in the population. And it looks like if you use very well the modifiable risk factors knowledge we're going to talk about today, you offset that genetic risk, especially if you have only one copy. Just a word about familial Alzheimer's. These are very rare families where Alzheimer's starts around age 40. The youngest families are in Colombia, where the onset is around 35. These are very rare people who have one gene causing the disease. It's a dominantly inherited condition. We have special research programs for these families across Canada under the umbrella of the DIAN, D-I-A-N program. So finally, most people with dementia, it's not inherited, it is sporadic. But now we're going to talk about the modifiable risk factors, and I'm using this report, which you can download free of charge. Just use on your favorite search engine keywords, Lancet, L-A-N-C-E-T, Commission Dementia. Then you'll have a choice of year. Just go for 2024, and you will have this list and this illustration that we're looking at now. There's 14 modifiable factors. Some of them are more related to early life, up to age 18. And you see at the top, early life, this means before 18, stay in school longer. There's no specific minimum, but you should, based on epidemiologic studies in low and middle income countries, grade 6 would be a minimum to have some kind of protection against brain aging. The longer you are, the better in school, but it's never too late to go back to school. So some of you may want to, when they retire, go learn another language or register for a master program, go for it. It's never too late. Then you have a cluster in yellow here, what they call midlife. That's important. That's probably most of our audience today. It's ages 18 to 64 or 65 to be precise. And you see a cluster of factors which we're going to talk about that are mostly related to heart and stroke risk factors. And since Ontario is the predominant audience today, let me congratulate you, because before the pandemic, there was a reduction of number of people with dementia in Ontario that was measurable because of how good care you took of risk factors for stroke. You had what's good for the heart is good for the brain strategy, and we should learn from that. So we'll go over the specific items, and the last few late life, that's 60 over age 65, you'll see some common conditions, unfortunately, air pollution, visual impairment, that's cataracts, for instance, or diabetic retinopathy, and social isolation. And we learn hard lessons together from COVID pandemic, how harmful social isolation can be. So now we're going to go over these items. Notice there's a number next to each item. It's the importance associated with that specific modifiable risk factor. Importance in terms of a number of people who have the problem, such as hearing impairment, very common, and its potential modification impact on dementia. So we're just going to go over them together. Less education, that's the easiest one to talk about. As you grow through the teen years, you form brain connections. You will remember all your life some poems you've learned. I'm old enough to have learned Latin and Greek, and I still remember my alphabet in those languages. So these stick in your mind. You build connections between nerve cells. It's your brain reserve. Then as you move into midlife, you have hearing impairment, very frequent. That's why it has a high number, 7% modifiable factor. And it's been shown that if you improve hearing at whatever age in people who have hearing deficiency, the better you are. The other thing is if you prevent hearing impairment, so if you work in a very noisy environment, control the noise factor, etc. Careful young people who are listening to their favorite music very loud, that could contribute to hearing impairment over a lifetime. This is new from this last report from last year. LDL cholesterol is bad for your heart, your blood vessels, but also your brain, and reduction of LDL, which ideally starts around age 40, by diet or statins or combination of whatever works, has an impact years later in your risk of dementia. So that's new from this past report. Depression has been around as a modifiable factor for some time. It's a bit difficult to explain because sometimes with dementia, the early symptoms are social withdrawal, anxiety, and depression. So for some people over age 65, depression may be a manifestation of incoming or incipient dementia. But younger people, if they have recurrent depression, they're more at risk of dementia later in life. And the message is treat depression by whatever means is appropriate and well. Traumatic brain injury, this is something relatively recent. We've learned from football players that recurrent red injuries can lead to a chronic brain encephalopathy, chronic traumatic encephalopathy. And as you know, perhaps from your experience, young people who have recurrent brain concussion are not very smart for a while after each event. So practical message, wear a helmet, avoid head collisions at sport. It's common sense, isn't it? But it's now a field of study, especially with professional sports like football and ice hockey. Physical inactivity is a risk factor, and that's one of the top ones in Canada, unfortunately. Same with the US. So lack of physical activity is part of the mix of vascular risk factors, diabetes, high blood pressure, high cholesterol. So physical inactivity is a risk factor. It's modifiable through physical exercise. And it's one of the top research interventions, which I'll talk about at the end today. What can you do about that? Can you prove that increasing physical activity has an impact on your brain function? The short answer is yes, but not big by itself. You need to do a combination of things to get the maximum effect from modifying risk factors. Diabetes, it's been around as a risk factor for some time. There's an effect on small blood vessels. There's some people who go as far to say Alzheimer's disease is a type 3 diabetes. I don't think that that's quite true, but diabetes mellitus type 2, the most common type as we get older, is a modifiable risk factor. And there's promising research with some of the medications used against diabetes to control blood glucose that may also reduce your risk of dementia. Smoking, an old risk factor for, of course, heart attack and stroke and lung cancer, but it's been shown to be one of the modifiable risk factors for dementia. It's less an issue in Canada than a generation ago, but it is a big issue in some countries like China. Hypertension, high blood pressure. So your top number, the systolic, should be no more than 130 on average. Over age 40, as young as 40, this is very important. If there's one modifiable risk factor that guys who are in their 40s should look at, it's your blood pressure. Don't let it go above 130. So physical exercise may be sufficient, cutting down on salt intake. Or if you need to take a medicine, take it. It's going to be for a long time. But the return on investment, lowering your blood pressure, is very important over the long view. Of course, over age 80, careful about lowering blood pressure. It may not be as relevant anymore. We can talk about that in the question period if you wish. Overweight, it's a risk factor, particularly noticeable in North America compared to lower and middle income countries. And maybe there's a generation factor. I think our children, grandchildren are a little bit more obese than the baby boomers. So something to watch. It's part of the constellation of risk factors we can modify. Excessive alcohol intake, that's a debate we have started during the pandemic where we all drank a bit too much. And what is excessive nowadays? Some Canadians guidelines would suggest no alcohol is better. Some French guidelines would say you need a minimum of 1 glass a day of a red wine. So somewhere in between, enjoy a good glass, but should be just 1 glass and perhaps not every day. Social isolation, that's a more difficult topic. As I said, we learned the hard way during the pandemic how harmful social isolation can be for the person who has dementia, for the person living with that person, and just old people alone, even if they have no dementia, it is a risk factor, and we should do our best to find out if our neighbors need a visit, help for snow clearing like this week, whatever. Air pollution, that's a relatively new one. For Canada, it's the forest fires that are sort of the, oh my God, it's happening here as well, not just in Thailand, Bangkok, where nearly every day there's a picture in the newspaper, or Beijing in China, there's pollution. For ourselves, when you look at specifics, it used to be smoke from wood fire and coal, kind of heating that was a problem. In our cities, we're cutting down a lot on using wood to warm up our houses in the winter. Or dementia and other conditions. Just trying to move the slide forward. Forward. So what about Canada? There was a study published sorry, you're going too far, too fast. Can you go back, please? Okay, just stick on that. So this is what is similar. Is it similar to what we just looked at the very beginning of the list of 14 modifiable factors? It's for Canada. People have looked at Canada more specific modifiable factors. So the common ones are there, of course, like hearing loss, but obesity, lack of physical exercise are more prominent than in other countries. And next one. Okay, now what do we do about it? Go back one, please. Okay, just stick there. So what do we do about these factors? So this is an example from Canadian investigators trying to modify some of those factors of risk and amplify protective factors in combination. So that's one key message from our talk today. It's better to combine protection factors modification. So an example, if you want to read, it's better to be part of a book club. You get more interaction with other people. You get more than just reading books. In this particular randomized study, they randomly allocated volunteers to who had mild cognitive impairment, so not dementia, just a bit of mostly memory decline, and they wanted to improve their balance and their thinking. The next slide. Okay, this is the design. So over 20 weeks, they had these volunteers aged 60 to 85, and they had, as you see here, aerobic and resistance training. So that's physical activity with cognitive exercise and vitamin D. So this is an example where you combine two modalities, physical exercise, training your mind, and a potentially useful safe medication such as vitamin D. An example in another study is metformin, one of the old drugs for diabetes and so on. So they were measuring cognition, your memory performance with a standard test. And notice that the treatment was over 6 months and then 12 months. So this is going to be one of the limitations of attempts to modify disease progression. You can do it only for so long. Whereas it may take 5 years to show a big impact. I'll just share with you that there's a program called FINGER, because it's out of Finland. It's a play of word. And Canada is very much part of that World Finger effort to have such trials in people, most of them over age 55. And you modify diet, vascular risk factors, and you add some physical exercise. So it's called multi-domain. So that's another concept perhaps to remember. It's better to modify 2-3 things to amplify 2-3 protective factors at the same time than to do just one thing. So just to, in a picture, show what was done, cognitive training, it's usually done with small groups, like 3 to 1. In Montreal, we had such a training program for memory impairment. It was 5 people with 1 coach over a period of weeks. Physical exercise, that's a little easier to handle. During the pandemic, actually, people were doing this at home with remote training and assessment and vitamin D. And these are the results, and it's something similar you will see in all these interventions. You see a slight effect on memory-like measures. The one surprise we had for the Montreal memory training program is that this effect on memory was sustained for 5 years. So even though the intervention is only 6 months or 12 months in this study, there may be a lasting effect over up to 5 years on your memory capacity. So for that particular Canadian study, it was encouraging. There was a measurable effect on some aspects of cognition. Vitamin D did not add to the effect of cognitive training and physical exercise. So to wrap this up, and I hope you didn't miss too much because there was some kind of difficulty with the internet, I understand, at some point. You see that we have 14 modifiable risk factors. We can talk in the question period, if you wish, about others that are upcoming, such as sleep and gum hygiene. Certainly for the Ontario listeners, thank you for showing that what's good for the heart is good for the brain. Prevention of small stroke, even silent ones, does have an impact on dementia risk years later. There are opportunities for Canadians, especially those over 50, to join observational cohorts. So you just are checked every year, but you're available for studies if some come up where you could be randomized to something like physical exercise, cognitive training, that's it, compared to maybe the same thing plus a vitamin or other diet supplement compared to something else. So you can get involved as research participants. And quite frankly, as a clinician, dementia risk reduction is the most cost-effective way for our society to modify the risk of dementia and having less people with dementia as we get older. Thank you for your attention.
Merci, and thank you very much, Serge. It was great. And just to hear you help to really bring the latest evidence to life. And again, what actually is happening here in Canada in terms of really trying to advance some of our understanding about the ways in which we can reduce our risk of developing dementia. Because as you said, there are close to 700,000 Canadians today who are living with a diagnosis of dementia. We estimate right now that that could climb to as high as 1 million people by 2030, 1.7 million by 2050. But I think, you know, if I can add to what you were saying is the good news of what we've seen in Ontario and other places, the good news for those who are watching is that we actually have less people living with dementia today in Canada than we expected would be living with dementia, you know, kind of say 15, 20 years ago when we were doing these studies, mainly because as we've been learning about more of these risk factors, for example, we're able to kind of better manage risk. And so the key goal of today's webinar is to really make sure that as many Canadians as possible are aware that there are things that we all can do. I think it was a positive message that you noted that it's never too late to learn. It's never too late to modify some of the things that we're doing to keeping our brains healthy as possible, and to try and help reduce our risks. So thank you very much, because that was very clear and that was very helpful. And most importantly, we've generated a number of questions already. And so what I might do is just start asking Serge some of the questions, and I will remind those who are watching today that if you have specific questions you'd like to ask to me or Dr. Gauthier, you can please put those in the Q&A box that you have at the bottom, and so this is great. So there's a few folks who've asked, Serge, that I like this question. They were saying that if you have diabetes or hypertension or depression, but they are now under control with medication, are they still considered risk factors?
Yes, they are risk factors, but you've modified them successfully. There you go. Well done.
Exactly. So again, it's one of those sorts of things where, as you said, right, if you actually help to manage them, then you're helping to further reduce that risk. We've had a few people who are interested in understanding a little bit more about how does hearing impairment contribute to the risk of dementia?
Very good question indeed. I've carefully looked at what they wrote in the Lancet Commission, and it's a relatively short explanation. You're not hearing, so you're not registering new information. You're a bit isolating yourself from the environment. That's simple explanation. The other thing they report is that there may be a vascular factor, like reduced blood flow to the cochlea, also affecting the hippocampus, the part of the brain that has to do with memory processing. Actually, that was quite elegant explanation. It just needs to be demonstrated more clearly. So it's a combination of factor. But clearly, the literature that they reviewed in that commission showed that if you modify with appropriate hearing aid the impairment, you reduce the risk of dementia. So there you go.
Absolutely. Perfect. Folks were also interested in asking a little bit more about this, the idea of that the lack of sleep being considered as a risk factor for dementia, or the idea that sleep apnea and dementia And is there any benefit of using CPAP as well? So some things connected to kind of sleep and sleep-related disorders.
Excellent question, because it is one of the modifiable risk factor potentially that did not make it into the 14 this year. And they do talk about that in their report, that there was just not enough evidence to show that not enough sleep is contributing to dementia. They don't specifically refer to CPAP, which is a risk factor for other conditions that for you perhaps can mention to our audience. So it didn't quite make it. Just for the interest of people who are really keen, the first part of your night in deep sleep, the first hour and a half is the most important to clear the amyloid out of your brain. Okay? So once it's done, the rest of the night is not so critical as far as the amyloid buildup. So I was surprised to find that out, and it's a bit reassuring because I do start to wake up now at various intervals, but I go back to sleep.
Perfect. And again, it's that really at least make sure that you're getting at least 1.5 hours of sleep. But obviously,
A
the
deep
more
sleep, yes.
but the more you sleep you get, sometimes the better as well. So because you
Yes.
can be well rested the next day. Um, People were actually interested, or oh, here's a good question from William, kind of asking, and I'll join this into another one that we wanted to kind of ask about, but in terms of William is asking, what would you say are the top three behaviors to reduce our risk of dementia? And I would also add on to the idea, like, are there some simple things that Canadians can do to improve their brain health?
Yes. Thank you for asking. Indeed, it depends a bit on where you are in your life. So if you're 14, male, stay in school, longer the better. If you're 30, working in a very noisy environment, wear the helmet, be careful about it.
Perfect. Okay.
Don't
And
let
are
it,
there
it depends on your life circumstances, actually. Yeah.
Mhm. Yeah. And if you were to say, if someone was to come to you and say, what are the three things you think I should start doing today? Or everybody's, of course, different, but what are the three things that you think have the biggest bang for their buck, if we can use that term, to helping to reduce that risk of dementia?
I think we just got the internet back.
Okay. Serge, I was just asking you the question, saying, are there three things? What are the three biggest things that you would say people could do to reduce their risk of dementia?
Okay. For Canadians, actually, whatever your age, it's physical activity. So just walk, preferably walk with someone or a dog or both, which is what I do. Um, get out of the house. Irregular walking has been shown to be more effective than just sitting around watching TV and so on. And a nudge above that is sweat a little bit. You walk fast enough to sweat a little bit. That's a value added. But again, do it with someone, talk to someone. The combination is better than just running alone wearing headphones. So that's a physical exercise. The other thing is training your mind. So we're good as Canadians to learn a third language. Let's keep doing that, because it's been shown that additional language learned or really have a direct effect on brain cognition and volume. Would you believe? Some parts of the brain actually grow thicker when you're bilingual. So that's cognitive learning, and do it with somebody else. As I said, books. Yes, it's nice to read books, but talk about them with in a book club. It could be virtual or person to person. And the third factor would be mostly your own vascular risk factors. So whether it's diabetes, LDL, if you're shown to have a condition that requires treatment, just take your statin if you need it, take your a diuretic if you need it. For the long term, these are silent conditions, but you're preventing a heart attack, stroke, and perhaps dementia.
Perfect. Okay. One question that came in was in terms of one of the risk factors that was asked about was about vision loss, for example. And I believe that one of the new risk factors noted now is actually vision loss.
Indeed, this was a new one from the report last year. They specifically mention I checked the specifics. It's in an American study where if you have cataracts and you have them removed, you actually improve your cognition. just to show you the impact of having better vision, meaning better reading ability, better communication with people ability, look them in the eye. There's an effect. Of course, the retinal diabetic changes, that's something else. So that goes back to treating diabetes the best you can. If you need insulin, go for it. There may be other causes, of course, macular degeneration, etc. But if you do have cataracts, so it's a specific finding that go for it, have them removed.
Perfect. And then in terms of the, some folks are asking about kind of, are there other factors, for example, that didn't quite get into the, that are kind of, as you said, that the literature, there's increasing interest, but we just don't have the evidence to say that this truly is a risk factor, because someone was asking, what about air pollution, for example, air, noise pollution, or other, kind of hereditary factors, for example? Are there other things that are kind of at the cusp as things that could be reduced in terms of risk?
There's one I really like to talk about. It's actually mentioned and I did speak to the lead person of that report. It's coming for next time. It's having dental disease, chronic gingivitis, which is very common in our seniors, especially those who don't have the opportunity to brush their teeth on their own, who are in the chronic care. But chronic inflammation from gum disease may be a factor for dementia. It didn't make the cut because there was not enough publications in enough countries to back this up. But I wouldn't be surprised if it's part of the so-called systemic inflammation. That's also a possibility. It goes both ways. If you have chronic arthritis over many years, you're less likely to get dementia. That was the finding from Dr. McGill in Vancouver over 30 years ago. But that's possibly because you take anti-arthritic medications for many years. So it's not having the condition that may be protective, it's the treatment for it. So go back to buccal hygiene. Actually made a challenge to the Quebec Hygienists Association that they should help prove that better buccal hygiene is a protective factor against dementia. There's some studies done in the UK where they take samples of gum, they measure what kind of bacteria they can grow out of it, and if you modify that risk, does it make a difference a year or 5 years later? So watch that one. Under systemic inflammation, more specifically, gum hygiene.
Perfect. And then in terms of hereditary risk factors, I think some folks were wondering about, because you mentioned, for example, if you're thinking about people who may be younger than a certain age, that's when you're going to think more about genetics being, an issue of concern. But I think one of the questions someone asked was, they said, if both your parents, for example, have had a history of dementia, does that increase your risk as opposed to, say, one parent? But I also think you're probably going to speak to about, well, when did they get it and what was the nature of the dementia too? But would you like to expand on that a little bit more, Serge?
Yes, thank you for the question, because we always get that whenever we talk to either individuals, family members, or a group of people. What if we have both parents having dementia? So we say, what age were they? So if over age 90, it's just because they grew to that age where 1 in 2 have some kind of cognitive impairment and some of them dementia. Of course, if it's around age 70, whether it's one parent or both, there's that ApoE, apolipoprotein E4 gene that is common in our population. It's about 15%, 15% of Canadians have one copy of that, not defective gene, not as efficient gene, we should call it. It's a gene that controls the capacity to carry cholesterol into your brain, into your nerve cells. If you have both sides of the family giving you this for 4, yes, you're more likely. No, I should say that very carefully. Your risk is higher than average population to get dementia, but it doesn't cause the dementia. And if you have only one copy, which is 15% of the population, it's already been shown that if you control the modifiable risk factors very well, as one of the person already said, I control my diabetes, I had depression, it's under treatment, it levels off the genetic risk for that 15% of the population. So there's that 3% that has the double 4, 3% of the population in Canada that perhaps deserve a special attention. And if we have those specific dementia prevention clinics set up the way we do for heart disease clinic prevention, that 3% of the population with double 4, maybe they'll get a special interest for research and eventually therapy.
There are some questions coming about the issue of kind of diet, for example. And so someone, Kevin, was asking about is there a lot of chatter about, for example, the Mediterranean diet? And then some folks were actually asking about the use of vitamin D, for example, saying that it's been used in some studies to look at, potentially it as an opportunity. But any comments about, say, diet and vitamins in particular?
Thank you for the question. Indeed, it is mentioned in the Lancet Commission report. There's just not convergence in the reports to say that one diet is really better than the other as far as dementia risk reduction. Certainly the Mediterranean diet, which is no beef, mostly chicken and fish, and olive oil, good quality olive oil, is better for the heart and perhaps general health. It's not specific to dementia. As far as vitamin D, it was specifically tested for in the Synergic study, and it did not add value over a year. If you combine that with the physical exercise and cognitive training. But vitamin D you may need for osteoporosis prevention anyway, but don't take extra doses because then you may actually harm yourself. So there's a limit to how much vitamin D you should take per day or per week. It's the same for supplements in general. So folic acid in high doses in some people can cause actually delirium. So you should not take vitamin supplements if you don't have a deficiency in a specific diet constituent. Remember those of you who are vegetarians that you're all B12 deficient? Because there's no B12 in vegetables. So you do need to take a B12 supplementation if you're a strict vegetarian.
That have been coming up about head trauma and kind of concussions and so on. So there's just one was saying, in case there is head trauma induced dementia or sporadic memory loss to parents or in family in their midlife of an older adult life, then that can be passed on genetically. Is that again linked to the particular gene that Dr. Serge mentioned? So there's a question about, I guess, head trauma, and someone actually asked about the nature of head trauma. Is that something where someone may have fallen and actually hit their head, for example, versus if they say, they might have experienced kind of whiplash and they might have had a concussion, but not necessarily contact with the hard surface and so on. So any comments about relationships between types of head trauma, if you will, and then also anything connected, does that influence genetic risk?
Yeah. Thank you for the question. Indeed, I have one of my neighbors who had a whiplash, and to my surprise, she was really a bit, let's say, disorganized in her thinking for 2-3 weeks. So I realized, oh my God, just having one time a whiplash can indeed interfere, but it doesn't cause dementia. When we say a chronic traumatic encephalopathy, it's really recurrent head injuries, such as a football player, a ice hockey player. It's recurrent trauma. Boxing is the classic example also. So all of us, we do have a head injury for whatever reason in our life. And yeah, we may be a bit mixed up for a few days, no problem. Just to link with the point that was made by the listener that ApoE4, if you have one copy, should you be extra careful with head injury? Avoid contact sports. This was actually debated about 10 years ago, whether we should screen genetically for ApoE4 kids who want to go to play ice hockey. But that was not accepted. But If you're double four, I would not send my kid to a ice hockey team. I would not join a soccer team. But this is 3% of the population. So this is something we'll have to decide as a society. Do you want to do genetic testing for risk associated with head injury and eventually later in life having dementia? Remember that if you're found to have double four, it will be in your medical file for your life. It will interfere perhaps with your employability, insurability. All your children will have one copy. So there's also an ethical consideration in linking genetic risk with whether you join a hockey club or some activity where you would be at higher risk of head injury.
Okay. There's so many good questions. Now, just so you know, Serge, you've been a trooper here. You've answered over 32 questions so far. I'll give us just a little breather at the moment, and then we'll go back into do a few more. But this has been terrific, and people are really appreciating, as I am, and the rest of our team, your absolute expertise in this area as well. Actually, someone just asked about how can we find out if we have the APO gene? How do we get tested for that, for example? And I think you've already answered some of the other questions that were related to the gene about what it might mean if you have that as well.
Careful what you wish for, because you
Mm-hmm.
can get the test done commercially. You just send your blood somewhere. It's done in the States. I don't think it's available in Canada just like that. But it was part of the lipid profile until about 15 years ago. Because if you had ApoE 2, 3, or 2, it meant something special about your heart risk. And then people would find out, oh, I don't have 2, 2 or 2, 3, I'm 4, 4. I'm so glad. 15 years ago, they could say that, but now they can't. They would be very worried the rest of their life. So I would actually discourage you to do this testing unless it's part of conversation with a physician who's aware of the genetic impact for yourself in terms of insurability, employability, and your children.
Perfect. Now, switching gears a little bit, and I think from a gendered perspective here, because we know women have increased rates of dementia at different age groups, and so one person was asking if women have an increased risk, perhaps because of lowering levels of estrogen. Do you think HRT could lower the risks of dementia?
Sorry, the last part of your question?
Was if should someone say take hormone replacement
Oui,
therapy?
yes. Very good point indeed. This has been debated for about 20 years. There was one study involving many Canadian women where they were given a supplement of Premarin,
Hmm.
relatively high dose versus placebo, and the risk of dementia actually increased compared to what was expected. So that sort of halted the whole field of estrogen supplementation for reducing dementia risk. So it may be a topic of interest to bring to your audience later this year, this debate about estrogen supplementation. It could be just symptomatic for the duration of the menopausal months or years, but should you stay on it for long term because of dementia risk reduction, that you would need to bring experts about. It's a controversial field right now.
Mhm.
How long
Now,
you should stay on hormonal supplements if you need them for symptomatic relief.
right. And then Helen was asking, like in some older homes, lead pipes are in existence. Has lead contamination been explored as a link to dementia?
Sorry, repeat again what was
Um,
tried?
the question was saying, in some older homes,
Yeah.
lead pipes are in existence. Has
Oh, lead
lead
pipes.
contamination been explored as a link to dementia?
Uh, that would be metal
Hmm.
impact. The Canadian topic of preference is aluminum.
Hmm.
We had some really good researchers in Toronto, for instance, and aluminum injected in the brain of a rabbit will cause Alzheimer-like changes. But the aluminum you would get exposed to in your daily life, whether it's antiperspirants or whether you cook your in an aluminum pot, that kind of aluminum doesn't get into the brain readily. Uh, Thank you for bringing lead. It's an old topic. I hope we don't have too many lead pipes left in our homes. This was known to cause a problem with children, a specific syndrome. And for adults, at my recollection, it was mostly neuropathy, like a dropped wrist, a peripheral kind of changes rather than confusion or certainly not dementia. But thank you for the question.
Okay. Okay. Just looking, there's so many more questions that keep coming in, so this is great. Let's see here. So one question people have is kind of, you've mentioned that there's various research studies that are being done. People said, how do I get involved in a research study that might be occurring?
Oh, I'm glad that person asked because I'm hoping people will get involved. This is how we make things better for ourselves and mostly for the children and grandchildren. We've had a cohort at McGill for the past 8 years. It's about 400 to 500 active participants. They get lumbar punctures every year, 3 PET scans every year, memory tests, blood, and they are so eager. And there should be something equivalent perhaps in Toronto, in Vancouver, hopefully in Calgary. Um, these are observational cohorts where we learn about normal aging, whether you have one copy or not of this ApoE4. Then you're first called because you're on standby for intervention studies that could be not medicines, but rather exercise, etc., under supervision, and new medicines for those at very high risk, such as the double fours. So please get involved. How do you get about that? It depends a bit where you live. In Montreal, you would look up the Fédération des Sociétés Alzheimer du Québec website. In Toronto, perhaps your Ontario or Toronto Alzheimer Association, they may have updates on what's available for observational. Remember the words observational and interventional. That means intervention that does not necessarily mean a medication. Yep, that it's one of the things that you would really like because you get a checkup. You'll find out about your biologic profile as it is right now, and perhaps you'll have an extra edge about knowledge about modifiable risk factors, or you'll be more motivated to use that knowledge about modifiable risk factors. So go for it.
Okay. There was a question here that came in about, has long-term regular cannabis use been identified as a modifiable risk factor?
Sorry, long term?
Cannabis,
Oh,
cannabis.
cannabis.
Yeah,
Ah, we don't know.
yeah.
This is something that's being studied. There's a special program under the CIHR, the Canadian Institute for Health Research. We don't know what chronic cannabis use will be. Maybe in Lancet Report 2050, it will be the 20th a modifiable risk factor.
Perfect.
Perhaps in some individuals that have biological risk that we will know more about by then.
Perfect. And then someone was asking your thoughts on metformin for non-diabetics to help prevent dementia. I think there's always a lot of thoughts about metformin.
Wait, it's being used right now in one of the so-called finger worldwide studies. Uh, we'll see what happens, but it's really done well, so we'll have a definitive answer whether metformin can be in non-diabetics helpful. There's another class of drug that perhaps people know about, the GLP-1 receptor agonists that are used for lowering body weight. They're also being tested for people who already have dementia, and people at higher risk. We'll find out about that over the coming year or two. Another topic for your exciting program.
Absolutely.
Allowing me to add to our audience that if you want to read some of the material that we have at McGill, go online, just do McGill CA/dementia. You'll have access French and English documentation. And one of our booklets of information for people who have mild cognitive impairment, it's available in 14 languages, including Ukrainian.
Thank you so much, Serge. And I want to point out that these resources are excellent resources. Again, as Serge has noted, the companion guide is available in 14 languages. There were a few questions that we weren't able to answer about signs of dementia and and some of those aspects about mild cognitive impairment versus dementia, this is where the guide becomes
Yep.
really helpful. And this is where a lot of your questions can be answered. So there's a treasure trove of resources that Serge and his group, Claire and others have created. And so we want to just call this out as some things that we really are very proud to know of and promote as the National Institute on Aging. So Serge, you've been an incredible sport in terms of, again, sharing your knowledge, sharing your expertise, answering a whole bunch of questions that have come in from our engaged folks as well. So I just want to say thank you and merci for that. And also that we also have other resources we wanted to point out, folks, as well. So in addition to the McGill Dementia Education Program that you see, the URL that Serge mentioned there's also the McMaster Optimal Aging Portable. They have a dementia risk reduction e-learning platform called dementiarisk.ca. There's also the Defy Dementia podcast that Bakebreast has produced, and so you can look at that if you're a podcast learner. So lots of different resources and good ways to help you kind of learn more about ways in which you can protect your brain, from that perspective. But Serge, I wanted to, before we close off today, were there any other final thoughts that you wanted to share to folks? You've shared a huge amount of information, but I wanted to be able to give you just the last minute or two to kind of any kind of words of wisdom or guidance, because I think sometimes people are just say, I don't even know where to start and how to approach this. So you already kind of talked about some important things like just going for a daily walk, for example, and just kind of being mindful of if you have any chronic health issues, what to do. But any other words of wisdom as you've been thinking over your extensive career in looking at this, any final words of wisdom that you'd like to share with our audience today?
When you go out for your walk, maybe check on your neighbors, get them out. Maybe you build a age-friendly community. It's something we should do well in Canada. Get away from the term dementia-friendly, just say age-friendly community, and we stay home longer.
Mhm.
Yeah.
Brilliant. Yeah. And I think this is the key thing. I think what we want to really impart today is that, I think many people are afraid and are worried about dementia. We know that we're going to have more people living with dementia over time. But I think the key goal of today's webinar was to help remind ourselves there's actually a lot more that we can do today than we ever knew before to help prevent or reduce our risk of developing dementia. And so I think hopefully today's presentation was helpful to let people know that there are many things that we can do and many things that we can do to support ourselves, to support our friends and our families, to really kind of create these age-friendly communities, but also approach healthy aging in a way that not only helps you live longer and more independent, but also with a reduced risk of dementia. So again, I want to say thank you very much to my colleague, Dr. Serge Gauthier at McGill. And again, I'm Dr. Sinha from the National Institute on Aging. And thank you very much to everybody for being with us today.